that. So the last 3 minutes, I'll just quickly talk about another case. So when we think about, this is a case of delayed annular rupture. So the annulus has several components above and below. I won't go into the anatomy, but the risk factors can be if there is severe calcification, either in the subannular apparatus or in the annulus, and if it's traversing the annulus, especially there's an nodule, and you post dilate because of the PVL, that's a problem sometimes. If you really aggressively oversize, especially if you're trying to do it for aortic regurgitation, sometimes you can cause anterior injury like that. And there are many ways to manage it, conservative, surgical, and percutaneous. This is a case of a 91-year-old lady. She had CKD stage 3 and AFib actually with, she was taking Eliquis 2.5 BID, which is apixaban. She presented with severe aortic stenosis, mean gradient of 45. It's not a surgical candidate. This is her anatomy. So she had a small annulus. Her annulus is 318, LVOT is 277. But you can see how severe and hostile calcium is. Moderate to severe MAC actually, which continues into the aortic mitral continuity, and that's the 4D rendering. So we placed a 20 millimeter sapien, but immediately with the deployment, the patient became hypertensive, and it's evident that that's like a massive tamponade. We were able to quickly perform pericardial centesis and gave a lot of products like protamine, platelets, FFP, cryo, everything. But even 2 hours later, the patient continued to drain into the pericardial drain. So at that point, we remembered that this patient was taking apixaban, which had been stopped 48 hours prior to the procedure, but because she has chronic kidney disease, it can be really still hanging in the system. So the way to counteract apixaban can be with prothrombin complex called prothrombin PCC, basically, they're activated or inactivated, or the direct reversal agent, which is the andexanet. So just a quick review of the coagulation pathway. Without going into too much detail, the PCC is basically acting against factors 2, 7, 9, and 10, and the 2, 7, and 9 are inactivated, and the 10 is activated for in the FIBA or the APCC. So you can actually administer that and get very quick reversal of anticoagulation. And so it's important to remember these agents when we're doing these procedures. Obviously, they're very expensive. In case of dabigatran, you can actually even dialyze the patient. So some considerations here are remembering the half-life of these agents, stopping them, and in patients with chronic kidney disease or advanced stage, stop them even before 48 hours because they could be hanging in the system, and I'll leave it there. Thank you.
Thank you, Aakriti. Please join us. I think in view of time, we are now going to go to the live case that Dr. Sharma has been waiting. Can you switch to the live case to Mount Sinai, please? Thank you.